Hello, my friends. How are you? This is me, Dr. Sergio Rovensky from Shoulder Planet, here from the city of São Paulo, Brazil. In this video, I'm showing you a very interesting arthroscopy video, shoulder arthroscopy video about how to do a long head of the biceps tenodesis in the greater tuberosity. We can do it arthroscopically in many different locations, in the conjoined tendon, in the lesser tuberosity, in the subscap, in the biceps pulley, in the supraspinatus, and even in the greater tuberosity. And this is what this video is about. So I hope you like the video. Please don't forget, subscribe, leave your comment, give us your thumbs up, and let's see the video. Anterior superior lesions are quite well described in shoulder literature, and they have a strong relation with subacromial impingement, as we all know. In this present case, I'm presenting a case of a 54-year-old man who started to have pain over his right shoulder about 3 years ago. He came to my office in August 2011 with clear signs of cuff pain and impingement too. His physical examination resembled very clearly a cuff tear, and so this is his MRI. So this is a T2 coronal image in which we can see a supraspinatus tear about 2 centimeters. And in this other image, this is an axial T2 image in which we can see a complete tear of the very anterior part of the supraspinatus. And finally, this is a lateral T2 view in which we can see a complete anterior tear of the supraspinatus. And arthroscopy was indicated, and the arthroscopy was done in November 16, 2011. And so this is his arthroscopy. So this is his arthroscopy. This is the right shoulder. We're establishing anterior portal with a spinal needle. Then we entered with a soft tissue shaver. There was a huge amount of synovitis underneath the biceps anchor, so we would have to remove it all. Now we are cleaning just the inferior synovitis underneath the biceps, and as we pulled the biceps out of the biceps pulley, we could see that the biceps was very ugly with a lot of fraying, really a very ugly biceps. So definitely that biceps would have to be tenotomized or even tenodesed. So we performed a very simple and fast biceps tenotomy, and then we took a fast look at the subscapularis. Here we can see that only the upper fibers of the subscap had some fraying, so we would have to perform a very simple debridement of all that fibers, but this is a very fast part of the surgery. And then immediately we would have to go to subacromial space. So now we are working in the subacromial space, a lot of bursitis and synovitis. We would have to remove it all, and we can see now underneath the acromion very clear signs of impingement. So we would have to clean all that tissue until we found the insertion of the coracoacromial ligament. So now we're starting to release the coracoacromial ligament, first with a lateral cautery and then with a basket. Particularly in this case, the coracoacromial ligament was very hypertrophic, and we would have to remove all that tissue. Now we are still removing the coracoacromial ligament until we could isolate the acromion. So now we are seeing the lateral gutter very clean, and then the acromion was ready for acromioplasty. So now we are working, we changed the portals, now we are in the lateral portal, and then we establishing an anterior superlateral portal with a spinal needle, and then we entered with a burr to perform a very simple and fast acromioplasty. The acromioplasty can be performed with the burr entering from posterior or for anterior, as we did in this case. And after the acromioplasty was done, we started to look at the tendon. So now we can see the lesion with the biceps inside of the lesion. We entered with a soft tissue shaver to clean all the synovitis underneath the greater tuberosity and to start to prepare a bony bed in which we would put our anchors. At that moment, we entered with a shaver for the anterior portal just to clean the anterior gutter. This is a very important part of the surgery, and then we continue with the cleaning with electrocautery through the anterior superlateral portal. So now we can see that the greater tuberosity is absolutely cleaned, and we started to put our first anchor with a simple probe. So now we made an entrance, and then we entered with a 5.0 metallic double-loaded anchor, and we inserted that in a very standard fashion. That patient hopefully had a very good bone quality. So once the anchor was in place, we would just have to test it, and then we always like to isolate the sutures because we never want to make a mess with them. So we separated the sutures, the white one that must be isolated from the blue one, and then we initially used Espresso device, and we entered for the anterior superlateral portal to pass this first suture in the more posterior part of the supraspinatus. So now we are passing the first suture, and we are pulling it out of the shoulder with a suture grasper through the anterior portal. And then we would just have to isolate both legs of the suture in the anterior superlateral portal and tie the first knot. So we tied that knot with a sliding Duncan knot, putting a lot of compression in order for the tendon to heal in the bony bed that we had just created. Once the knot was done, we just would have to cut it, and at that moment we decided to test the mobility of the anterior part of the supraspinatus. Hopefully the tendon was very mobile, so we entered at that moment with a suture passer, and we passed the suture passer with a proline firstly through the tendon, the anterior part of the supraspinatus, and then passing through the biceps, as we are seeing now, because we wanted to perform a biceps soft tissue tenodesis through the rotator interval. At that moment, we passed the second suture, the blue one, through the tendon, but we unloaded that suture because we wanted the biceps tenodesis to be put a little bit more anteriorly. So we entered with a second anchor in a very standard fashion, in a more anterior part of the greater tuberosity, and once the anchor was in place, we would have just to pass one of the sutures through the blue suture that was passing through the anterior part of the supraspinatus and the long head of the bicep. So we did it with the white one, so then we tied the first suture of the second anchor, the second suture of the surgery, performing a biceps soft tissue tenodesis in between the rotator interval. So we put a lot of compression as usual, and then we would have just to cut that knot. And at that moment we still had another suture, and we decided to use an Espresso device, passing again through the anterior superlateral portal. And we would so pass a second suture in a more anterior part of the supraspinatus. Here we can see the acromioplasty, and then we pull that suture out of the shoulder for the anterior portal. And in the same way, we would have to isolate both legs of the suture in the anterior superlateral portal to perform the third suture of the third knot of the surgery. So now we are tying the knot, putting a lot of compression as usual, and then the knot would have just to be tied. And after that, here we can see the final construct. So as we internally and externally rotate the shoulder, we can see the biceps tenodesed in between the two parts of the supraspinatus, and the sutures were very strong. So then we took another look for the anterior superlateral portal. Here we can clearly see the biceps tenodesis in between the two parts of the supraspinatus. Here we are seeing the acromioplasty again, that was done in a very standard fashion, but it was very nice. And finally, we took another look in the tendon. So here we can see the biceps tenodesis, and it's very clear that it was in between the two parts of the supra, and at that moment the surgery was then finished. So my friends, I hope you liked this nice video about biceps tenodesis on greater tuberosity. So please do not forget, leave your comment, show it to your friends, help me spreading the channel, give us your thumbs up. And as Dr. Sergio always says, never stop flying. See you in the next video.